Good evening, Dr. Ruth.
Good evening.
How are you today?
I'm fine, thank you, other than we're having a technical hitch, aren't we, tonight?
Actually, we have tried to do our best, so there's no one to blame. First of all, I would like to thank you for your time and that you accepted to join me in this webinar.
You're most
We are
welcome.
gonna we are gonna lecture a lot of audience from Egypt and Middle East. First of all, I would like to introduce in a proper manner Dr. Ruth Brady. She is a dentist. Uh, she got qualified as a dental surgeon in 1981, and she have gone through a lot of training courses and have focused recently on non-surgical facial aesthetic procedures. Uh, Dr. Ruth is a multi-winner 7 times. Touch wood, okay? And she have managed to make a remarkable name for herself in the facial aesthetic specialty. Dr. Ruth, I'm gonna speak in Arabic right now, okay?
Okay.
مساء النور عليكم كلكم، رمضان كريم. يا رب تكونوا كلكم بخير. بعتذر على التأخير بس كان في شوية تكنيكال ايرور بخصوص البرزنتيشن بس اللي احنا هنعرضها. دكتور روث بريدي يا جماعة هي دكتورة أسنان في الأول وفي الآخر. نجحت إنها تعمل اسم كبير ليها في عالم التجميل. من الناس اللي شغلها تحفة وبقالها سنين في المجال ده. هي النهارده هتبقى معانا ان شاء الله عشان تدينا شويه من الخبره اللي عندها وتقول لنا ايه التجارب بتاعتها في الرحله الطويله في الفيشل aesthetic specialty. I'm gonna speak in English again once more, Dr. Ruth. When I first heard about Dr. Ruth, I actually saw her in a webinar with Dr. Tim Pierce. They were talking about the occlusion and the effect of the buttocks on the masseter muscle. And actually, I was fascinated by the subject and was totally amused by the way that she managed to explain this very sophisticated topic. Then I started to go through her Facebook account and her Instagram page. Facebook page, not Facebook account. Okay, Facebook page and Instagram page, and I found a lot of perfect cases, and I was totally caught with her approaches, especially the buttering technique. So I guess I will have to stop talking because I talk too much, Dr. Ruth. I'm going to leave for you the mic right now. Now you are totally free. Amuse us. Amuse them like you amused me.
Well, it's such a shame that we've had a technical hitch because we had the presentation of all my cases on just 2 hours ago, didn't we?
Yeah, maybe we can reschedule it another time.
Well, maybe that's fine by me. I had to come off the, it actually, I had to reboot it, and it could be that later on we might just get it back up again. But we can have another go in a little while, just to see if we can do it this time.
Of course.
Because it's very difficult to talk and explain without the cases in front of me, but
we will try to do our best.
Yes, you saw them earlier yourself, didn't you?
Yeah, I saw them. Dr. Ruth, could you please start with telling us how much is it important for a dentist to have a background about facial aesthetics and to know when and how and what to treat or what to refer if they are not familiar with the Botox and dermal injections. As I told you a little bit earlier, that in Egypt, most of the aesthetic specialty or the Botox and dermal fillers are mainly practiced by dermatologists and plastic surgeons. Very few dentists who know about the subject. So could you tell us, please, more, being a dentist yourself, how did you manage to learn this specialty? And how did you manage to make a great name of yourself in this specialty?
Well, it was a natural succession for me, I think, back in 2004. I think I came to the realization that, well, I've been practicing for 35 years in dentistry. And what I noticed 20, 25 years ago, we were making the teeth realistically fit the face. If the face was older, we were giving the patient teeth that had more yellow color, more fine cracks, so that they looked like they belonged to a patient of that age. Nowadays, and in those days, we would steer somebody that wore dentures or had wanted crowns and porcelain work, we would steer them away from anything that was too straight and too white, because we said that they looked false. And they did, because I regard the rest of the face as the frame, and I regard the teeth as the picture.
We were just focusing on the teeth, and we didn't give any attention to the outer frame of the face.
Exactly. So later on, people wanted whiter, straighter teeth. Bleaching came in. People were having their teeth bleached. And so denture wearers said, well, I want whiter teeth because people are having whiter teeth now. So we stopped dissuading them from having them whiter and straighter. But the problem was there was an argument going on between the perioral area and the lips and the teeth, the new teeth, and they looked just like people who had had false teeth or porcelain teeth done. Fortunately, at that stage, there were training courses available. We were starting in a very primitive way to use Botox, botulinum toxin, a prescriptive drug, and dermal fillers. It was delivered by needles, which we know needles are far more traumatic. Obviously, on the presentation, I was able to show full face transformation by cannula with no bruising at all. And initially, it was very, very primitive. It was really just around the lips and the perioral area that we were able to put a hyaluronic acid dermal filler, or some people use permanent, but we were using the non-permanent resorbable hyaluronic acid. And we were able to actually rejuvenate the skin and the tissue and the shape of the lips around the new teeth. But of course, what that then did was it left the teeth looking younger, the perioral area looking younger, but the rest of the person was still looking older. And so it's come.
The teeth wasn't fit for the overall face appearance.
It wasn't the done thing. It wasn't thought of. It was very primitive. People were not talking full face. They certainly weren't talking about profiles. So moving forwards over the last few years, it's become much more advanced. And now we're looking not just at the feature that the patient doesn't like, what I would call the lips, the inner frame, but we're looking at the whole outer frame as well at the same time. But we're looking at profiles much more, because if you don't get the profile right, you'll never get the front of the face right. So if you wanted to augment somebody's lips, for example, to make them into a more youthful projection and shape and size, instead of them rolling in and flattening off, you then couldn't do that very easily if the chin was too small. So it made you look at the chin. So really now you've got to look at the whole, profile. And this is where it also relates to the orthodontics, because an orthodontist can straighten the teeth within the alveolar ridge, but that's where they are confined to. If you've got somebody who's a class 2 jaw relationship, and the lower jaw, for example, is too small, an orthodontist can't correct a lot of that. They can only bring the teeth forward onto the ridge as far as possible, but they can't go any further without surgery, max fax surgery. But a patient often doesn't want that, or it's too mild. So the chin can be brought forwards, The chin also carries the lower lip with it, so the lower lip can come forward, and you can actually alter the perioral tissues and the chin to give a soft tissue augmentation
So
that
let me get this.
masks the problem.
So let me get this clear. In other words, you mean that Botox and filler injections have gave us a promising results as a camouflage for cases with a problem in orthodontic problem.
Absolutely. We can camouflage all sorts of skeletal problems. So we've got a multifunctional thing here with doing the facial aesthetics as we do. Incidentally, I call advanced facial aesthetics. I don't like that term. What is facial aesthetics? I don't think it's a good term. I like to call it non-surgical plastics. It's basically plastic surgery without the surgery. It's immediate results.
It's
If you do,
non-invasive technique.
I'm sorry,
Non-invasive technique.
non-invasive.
A non-surgical technique. Okay.
Exactly. And also with surgery, you've got months of recovery. With non-surgical aesthetics, particularly if you respect the tissues and you do it in a manner that is gentle and careful, you can actually go under the skin into the different layers, be it supraperiosteally or subdermally. You can go into these different layers and you can lay down a different viscosity of product that gives you projection and gives you a changed form. And with this, you can change the shape of the face, the projection of the chin, the projection of the lips. You can straighten off the nose. You can project the cheeks. You can straighten the jawline. You can do all of this and not leave a trace that you've even been into the face other than a tiny little mark. And that's what I do. I very, very rarely do I bruise. My patients very rarely have swelling.
Actually, I have been looking through your Facebook page a little bit earlier, and I noticed that you said that most of your clients are wives, and their husband thinks that they are just having manners, and they don't even know that they are doing any injections at their face.
Oh, absolutely. I would say that probably 90% of my patients' husbands, well, or wives, because I do treat men, or partners, I should say, to be politically correct these days, I would say at least 90% do not know that they come to see me. And they can have their treatment done subtly and incrementally. I believe in incremental build-ups so that they change. Sometimes they can change quite dramatically in one session. You've seen that case of Karen.
Yeah, I saw that it was a wonderful case, by the way.
I mean, you can find it on my Instagram, Dr. Ruth Brady Aesthetics, under the favorites, the saved section. It's under a category called Karen.
I actually saw it, and it was an amazing case, by the way.
Well, thank you. And I'm very frustrated that we can't bring it up tonight, but perhaps at the end we will just have a quick go. But
Dr. Ruth, may I interrupt you for a second? I have two questions.
Yes.
First of all, you said that we can inject fillers with different viscosities underneath the skin.
Yes.
So this means that you can use a different types of filler or different viscosities of filler in layers, as if you are building it in 3D or 2D dimensions. Is this right?
Yes, absolutely. I tend to use the ones with the, for example, I like to use Teoxane products and Restylane, but to talk about the Teoxane, you can go on top of the bone, on top of the periosteum, and you can use a material that has more lifting power, more G prime. And that can give you the projection in the deeper layers. And of course, the top layers on top, that's the muscles, and then the subdermal, and then the skin on the top. You can then project those forward into a better shape. This is particularly good on the cheeks, but sometimes I use a sandwich technique. So I go deep on the bone, and I lift out that beautiful sculptured shape that I want. But sometimes what I call the bedspread, the outer layer, can still be, particularly on an older person, there's not a lot of subdermal fat. So you need to sandwich this, because you can then go into that layer with something that's more spreadable. And I have a technique called buttering. It's a very smooth technique using a
Actually,
cannula.
I was fascinated by the technique, especially when you applied it on the white roll border, the skin border of the upper lip with a cannula. I have seen it.
Yes, I can literally go into the skin and I can spread it just as if you were spreading some butter, some soft butter under the skin of a chicken before you put it in the oven. And that's
And
why I called it the
I
buttering
you have
technique.
nice butter in England, especially
Yes.
that you're big in the countryside.
And therefore, my techniques don't need, you've seen my videos, they don't really need massage. I don't massage. I place it in exactly where I want it, and I come out. And you'll often see me on the videos just stroking my thumbs across the area.
We were just blending it. We were
Well,
just blending the filler. Yeah, I noticed this.
blending it or
We were talking a little a couple of days ago about this, that some practitioners depend on the massage to shape the filler. But what
yes,
you do on the opposite, that you already shape it during the injection.
that's right,
And,
absolutely.
and from this comes the skills, by the way.
Well, it's all I've ever, since I've been using cannulas, it's the only way that I see people doing it the other way, but I personally don't see the sense in that. I think I've seen people treating patients where they've placed it in different places, and then they have to use quite a rough gauze, which they spread across the face, and you watch the skin becoming very red and almost very angry. And the patient goes out with a very red face. And the way I do it, I really only rub my thumb over it to prove to the patient when she's looking in the mirror. I say, look how smooth this is. I don't need to massage. So the skin doesn't go red. I haven't rubbed over the skin at all. And I more or less stroke the skin just to prove to myself and to the patient that it's very, very smooth. So yes, I believe in shaping it up as I do it, the lips, the cheeks, the chin, and where it's going in superperiosteally, sometimes I just mold it a little bit, that's all. Just to nudge the shape. I like to look down from the top of the head if I was looking at the chin. And I just like to know that it's evenly balanced. I have a thing about symmetry. And I just like to make sure that it's beautifully symmetrical. But then I'll also go in.
Speaking of balance and symmetry, could you tell us more? Could you tell us more about the principles of facial analysis? I mean, when I asked you before, do you do a lateral cephalometric or you do measure with caliber? You told me no. I do have enough experience to see it, to spot the defect with my own eye. So could you tell us more about facial analysis? How can we know what is the real area that need to be treated? Sometimes patients come with you due to a problem in the lower third of their face, but when you do the middle third and you lift it, you give a perfect presence. So sometimes the patient cannot spot the real defect in the face. So could you tell us more about facial analysis and normal proportions?
I like most people, I divide the face into upper third, mid third, and lower third. I have a very long consultation process with the patient where we discuss, if it's a slightly older patient, we discuss the aging process about how the upper third descends, affecting the middle third, and then that in turn descends towards the lower face. We know for a fact that sometimes it's pressure, sometimes the different fat pads have separated and they put a downward pressure from the mid face the nasolabial fat pads come down and press onto the mouth. But we also know for the fact that we also get redistribution of fat. We get hypertrophy in more the jowl areas and sort of lateral to the mouth, but we get atrophy in other places on the face as well. For example, here. So we get things hypertrophying and atrophying. So we've got a bit of a mixture of, we've got muscle movement downwards, we've got loss of volume, so we've got collapse of the tissues, and we've got gravitational pull. And all these things lead to the face moving downwards. In fact, really, the platysma muscle is trying to pull the face off the face, like pulling a tablecloth off a table and onto the neck. And that's where it's traveling. And so what I do is I look at each third of the face with the patient, and we make comments on what is actually happening on that patient's face. And by doing that, knowing where we've got to put the tissues back, that starts to denote what treatment we're doing. So I always say, you have to know where the tissues started, where they belong, before you can know where to put them back. You have to,
this is important for the clinician, because we have to emphasize on some things, that sometimes Botox and filler are not the ideal line of treatment. Patient may need surgical facelifting. He may need to use facial threads. If the clinician doesn't know the aging process very well and doesn't know what had happened to the skin of the patient, he may need to use a lot of material of filler and Botox and may not give the satisfactory results. So it's very important to know the aging process.
Absolutely. And I have to say that
do you use facial threads?
I beg your pardon?
Do you use facial threads?
I have done some threads cases, but they're getting more widely used now. I've seen different thread systems come and go, and I've known of people who have had complications with them. Okay. And I have to ask myself, threading systems, it used to be said that they lasted longer than they do. I think with some tissues, the tissues are that heavy that the threads don't hold as well. They do on younger faces, I think. But if they're having to have this repeated every year, I'm of a mixed thought here, that I have one main idea when I'm talking to a patient about different treatments, and that is, if I needed them, and I'm sure I do in this area myself, because of my age, because I'm in my early 60s. But
you look younger, Dr. Ruth.
Well, thank you, but I've still got my own teeth, touch wood. But I ask myself, would I want this treatment doing to myself? And would I do it to my daughters? If my answer is yes, I am very, very comfortable at doing those treatments on patients. My jury is out a little bit on threads. I know for a fact that you produce they're collagen stimulating. It worries me that some people have problems with collagen knots if they come too superficial. I really, I would still wait it out with threads. The different types come and go, and I'm not convinced at the moment because I'm hearing too much controversy. And I'm sure I've done some very nice cases, but knowing that they don't last that long and that they do cost a lot of money to do properly, you've really got to have a surgical setup, I think. When you've seen my videos, you've seen me working. I mean, we have surgical hat on, everything is draped. I don't believe in the ways that it's carried out in some clinics and establishments where You know, I treat every case as if it's a surgical case, even though it's non-surgery. I think we'll be doing this even more widely after COVID-19. When everybody goes back to work, I would hope so. But to do a good threads case, people do it very quickly, very swiftly. But I think it's very expensive. And I think those patients sometimes, they may be better off having a light facelift and a neck lift done. So I might be speaking controversially, but everybody's entitled to their own opinions here. I can, as you've seen, do some wonderful things with the face without using threads at the moment. I'm linked up with a nice plastic surgeon in Leeds. He sends me, he really does recognize when he has limitations in what he can do. He can do a facelift on somebody, but if the lips are shrunken, rolled in, he can't do anything about that. So he sends a lot of cases to me now, and sometimes I'm sending them back where they've got sort of soft tissue.
Excessive sagging in the skin. Yeah.
Pardon?
If they cannot be treated properly by Botox and filler, if they have excessive sagging in the prejudicial sulcus area, then they may need a surgery.
Absolutely. It may be that in some people's hands, threads
Doctor,
are...
there's a certain age beyond which you say, I can't give you a filler. This is not going to give you a good results.
I wouldn't put it at age particularly, because different people are different for their ages. You know, you have some people who are really...
It is more of an aging curve. It depends on the diet, on whether he put a sunblock or not when he goes out in the morning. And it is
very much. We've got the environmental issues. We've got smoking. We've got sunshine, UV. We've got stress with its catabolic steroids, hormones. We've got, you know, sleep deprivation. That all comes with it. And then there's sugar, the effect of excessive sugar. You know, that in itself causes a lot of problems, diabetes and increased infection. So I think I always say to a patient, there's a lot that I can do for them, but they need to do their own homework as well. They need to have a holistic approach to everything. I tell them what I can change. On young people, it's absolutely amazing.
They need to maintain what you did through their own lifestyle.
Absolutely. Otherwise, and it's not just that, but it's also cosmeceutical skin products as well. Things like retinols, vitamin C's, that make the skin so much smoother, which the downside is it becomes a little bit shinier, of course, but the skin itself becomes much smoother. So it really is a multi-layered approach. And you tend to find with young people, if they need something doing, it's just an enhancement. It's a change, either a change in the skeletal shape. The case of Karen, she had very flat cheeks, and we made those into beautiful, beautiful sculptured cheeks, and the chin, and the lips, and the jawline. And you saw the case. I mean, she turned into a stunning girl. Pardon?
It was an amazing case. It was an amazing case. Unfortunately, we couldn't actually show it to our audience today due to the technical error, but I hope next time we'll be able to show them the case. Doctor, I was going to ask you, could you tell us, or could you tell our audience, which I told you before, some of the dentists have they don't have enough information about Botox and filler. Could you tell them what are the uses of Botox and filler, and when can we say that we should treat this area by Botox, and when
okay. Well, there's a tremendous, they're completely different, but they work in synergy with each other. So the botulinum toxin is a prescriptive, it's a prescription only drug, and we use it to weaken the negative muscles. Most of the muscles on your face actually are negative. There's really only one or two that lift up. That is the frontalis muscle, the zygomatic major and minor muscle. And obviously the little muscles of the eyelid, that's inconsequential, you know. We've also got the muscle, the rosaurus, which kind of goes, I call it the neutral muscle. But the frontalis muscle lifts up, and so does the zygomatic muscle, which pulls us into a smile. And those muscles, we want those to be empowered so that we can lift the brow, we can make the face a more smiley, friendly apparition. What we don't want are the negative muscles, the depressor angular oris muscle, for example.
To give a sad look.
It gives a very sad look because they don't feel sad necessarily, but they look sad. And that's the sad thing. They have what we call sad face. The orbicularis oculi muscle, which pulls down and gives ptosis of the brow, which is fine on a man. But it's not really a good look these days by fashion on a woman. A woman wants a more lifted brow, which opens her eye better. Whereas a man looks good with a ptotic brow because his eyes get smaller, and for some reason he looks more sexy that way. Whereas a woman should have a wide open, doe-eyed look. Now there is another muscle which lifts up, and that is one that we don't like the look of, and that's the one that creates the gummy smile. And I know you've done a thesis on this, Noury.
Actually, I have.
That's the sneer muscle.
Yeah, I studied the issue very clearly. There are three muscles which are responsible for the elevation of the upper lip: the levator labii superioris, levator labii superioris alechnisi, and zygomaticus minor. You know, I have been asking you a little time earlier, where do you inject for treatment? Where do you inject your Botox for treatment of gummy smile? And where?
Well,
1 centimeter from the ala of the nose.
I think you've done a lot of studies on this, haven't you? And I think you tend to inject slightly laterally to where I would really. I think I would be in a compromised position to where you are. You're about 1 centimeter, did you say, from the alar of the nose?
Exactly, yeah. Exactly.
Whereas
at this point it's like the point of intersection of the three muscles that are responsible for the elevation of the medial portion of the upper lip.
Now, I tend to go in a little bit more towards the nose, in a middle depth at that stage. But sometimes if they've got the lift in the center as well, and we want to just calm that down, then sometimes I will, the depressor nasi septi, I will just go in just under the nose. But the danger is making the smile too stiff. So I'd always start off cautiously, and on that first occasion, top them up if necessary, but never to give them too much in the first place, because then their smile is inhibited.
So how much is the dose that you use, Dr. Ruth?
Well, personally, I would go anywhere between about 3 units of azulure to 7.5 units. I don't think I've ever used any more than that. And I do tend to find that it weakens the muscle, and it often lasts about 9 months in that situation. And then the smile starts to creep back up again. Now, at different parts of the world, the amount of gum show is regarded differently. So, for example, I think in Russia, they don't really show much at all. African races will show, it's absolutely normal to show a lot of maxilla and gum. I think America have the idea that
it depends on the race and it depends on the sex. Most females do have a gummy smile more than males, and younger age more than older age, because in older age they do have an upper lip sagging, which the upper lip is typically dropped downward.
Well, I have a theory on men, actually, particularly if you look at newsreaders, for example. It always used to interest me in dentistry how everybody always used to focus on the upper smile on men and in women. And actually, I used to watch the news, and I would notice that when the newsreader was talking, if it was a man, he was showing more lower tooth and often not showing any upper tooth at all. And therefore, in restorative dentistry, I used to think, why are they restoring the upper teeth when the lower teeth are the ones on show?
Okay.
But yes, a woman tends to have a more bowed up, a shorter upper lip in general. A gummy smile, of course, can be either you've got a vertical maxillary excess. You may not have a short upper lip, but you may have an excessive maxilla showing. You may have a short upper lip and too much maxilla. You may have just a very short upper lip, but a very normal maxilla. It's all about that balance, and that's what you've got to decide, really. There will come a point at which you cannot drop the lip too much without spoiling the smile. So it's a compromise situation. And I have to say, I've had some really, really happy cases with that. It's something that is very, very rewarding to do, and often goes hand in hand with people who have the chin is too small, retrognathia. So what I have a little concept is, on people that have what we call incompetent lips, those are where they have to really contract the oral tissues, the oral muscles, including the mentalis muscle, to close the lips together like that. And they go very orange peel on the chin. It's like orange peel effect on the chin.
Mentalis strains, they are trying to force to pierce their lip together.
Exactly. But I have a theory, really, that if you use a little bit of toxin to drop the upper lip and stop it lifting as much, but I call the lips the curtains. If they don't draw across the window correctly, I like to augment the lips as well, so that it's easier to close those curtains. I tell the patient that if their mouth was equivalent to a window where somebody has skimped on the curtain material, they haven't put enough width in, they have to drag the curtains across like this. But good curtains, you just tap them and they meet beautifully with a little bit of room to spare. And so I like to stabilize the lip with toxin, and then I like to augment the lips so that I give them more width. And I also will often augment the chin, because the lower lip is connected to the skin of the chin. So when you bring the chin forwards, you naturally reposition that lower lip. By dropping the upper lip a little bit, you already bring them into a closer proximity, and then you finally shape them.
We are doing all this in respect to the E line, the Ricketts line, which is a line is corresponding to the tip of the nose to the chin.
Well, right? Yes, absolutely. Yes, I call it, I tend to go back.
Yeah, I want to ask you a question. One of our audience is asking, actually this question came a little bit too late, but I guess you will be kind enough to answer it. Which kind of patients, Dr. Ruth, you refuse to treat in such non-surgical plastic? If you want to answer it at the end of the lecture, it's okay. If you want to answer it right now and return to what we were talking about.
Who would I refuse to treat non-surgically, did you say? Exactly. Yeah. Well, I think apart from talking about patients that have a psychological problem of, say, body dysmorphic, morphobia.
Dysmorphic
yes.
disorder, yeah.
Yes, I mean, obviously, after screening out a patient like that, where you would want to have a sort of psychological chat or refer them to a psychologist, if it's a patient that, or everything else being equal, I think that most people can benefit from non-surgical techniques. It's just that you can't sort out the whole face if they do need surgery. So whereas surgery cannot sort out the whole face either, I would say this middle third, particularly the mouth area, the perioral area, they really do benefit from both surgery and non-surgical techniques. And that's why I think it's very good for dentists, people doing non-surgical aesthetics to team up with somebody that does surgery. And I do believe that people who are surgeons, a lot of their skills in the past, particularly the older ones, the old school, their entire training has been scalpel based, scalpels, periosteal elevators. You know, they have been used to those type of techniques. Now,
They are
dentists
they
were
didn't fully catch the new trend of non-surgical interventions. They are still working with the old methods.
I'm sorry, Noury, I missed the end of that question.
I said that you were speaking about the old school, that they are still using the blades and the surgical interventions. They didn't fully catch the new trend of non-surgical interventions.
I didn't mean that those people are old school. I use the term in a traditional sense that some plastic surgeons who are extremely good at surgery have been doing it for many, many years. Some of them do not use non-surgical methods at all. They refer on, or sometimes they do it a little bit, but their entire career has been using different tools and different skills. Now, this is where dentistry comes in, because dentists are very much from day one, we've been working with syringes. We've been giving gentle infiltrations, which we have to learn to treat patients without pain. We don't inject fast. We're very, very slow, keen, controlled injectors. And so when we moved on to doing non-surgical aesthetics, facial aesthetics, using our instruments are injection syringes, albeit with cannulas a lot of the time. The actual way we hold the syringe, our plunger control on the end of the syringe, the way we can weave in and out, and we can move forward with the plunger and backwards with the syringe at the same time, going in opposite directions. It's a bit like they say you rub your tummy and you can rub your head. You often can't do the same things in the different directions. It's two different things. And I therefore think that we are very, very adaptable. We've got all the right skills. We've got the powers of facial analysis. We're using them as a dentist all the time. We've got knowledge of what goes on behind the curtains. We know what the teeth, the jaw relationships are. We know how the position of the tooth affects the soft tissue, both of the cheeks and the lips.
So, in other words, dentists are the ones that are fully qualified to practice facial aesthetics. On the contrary, plastic surgeons and dermatologists are the ones who should have a dental background.
I believe that they should very much have a dental training, certainly, in the same way that dentists, such as myself,
What happened when you gave the webinar with Dr. Tim Pierce? You have made them take a look on something that they didn't fully aware of it.
That's right, yes.
They inject Botox for the masseter muscle for purpose of aesthetics, but they don't have any clue that this may affect the function of the whole masticatory apparatus.
Well, absolutely. I respect Dr. Pierce very much, Tim Pierce. And I think even more so because he was so open-minded to the fact that when he saw a comment of mine on a Facebook aesthetic post, that people were asking some questions. Why does botulinum toxin in the masseter area not last very long? And I put in a comment to say, well, unfortunately, you're not taking away the cause. And I explained in this post.
Other muscles are gonna act as a compensatory mechanism for what happened. It's a group of muscles that are working together in harmony. You stop one muscle, but the other muscles are gonna compensate for its action.
Yeah, absolutely. I mean, when you put your molar teeth, your premolars and your molars together, which actually it's only about 12 to 15 minutes a day. That is actually about 2,000 swallows and the end of a chewing stroke, 3 or 4 meals a day. Somebody's added these microseconds up of contact of the tooth tissue, and it adds up to normal function being about 12 to 17 minutes a day. Now, that does not create any wear on the teeth at all, and it doesn't cause hypertrophy of the muscles. What's then happening is, due to the way we carry stress in the upper body, if we are certain types of personalities that clench our teeth together or grind, and that is all due to a neuromuscular argument going on between the muscles of mastication, where the jaw joint fits in place, where its ideal position is, and the brain, there's a neuromuscular pathway going on, because the muscles know, that the brain knows that the jaw joint is not in its best optimum resting position, which is in the anterior superior part of the fossa. And it knows that because the muscles are only relaxed, and that's the 7 sets of, well, really, I should say that the 4 main muscles are only relaxed when it's in that optimum position. If it's not in that optimum position, because of where the teeth lie, and the teeth win the argument, because they are also on the rigid jaw, if the jaw joint isn't where it needs to be, then those muscles are either in stretch or contraction. And the brain...
They are in a constant strain. They are trying to pull it back to its original position.
Exactly. So if it's the interferences, the cusps on the teeth that are preventing the jaw from sliding into that optimum position, and it can be microns only, almost you can almost not, sometimes you can actually visualize, you can actually see the slide, but sometimes it's so minute. But yet the proprioceptive system is so tremendous. The brain knows about it, and what it's trying to do, particularly out of your conscious control when you're asleep, it's actually instructing the muscles in this neuromuscular pathway to grind those interferences off the teeth so that the jaw is able to sit where it optimally wants to sit. If you have a jaw relationship that's different, for example, it is like a class 2, division 2 with a deep overbite, you'll find that you can't really grind because you're locked in. So those people, such as myself, particularly the types of characters like type A characters, who are very, very, they're very pernickety, they have obsessions with parallel lines. They like to be very neat and tidy. Everything has to be precise. They have a very low tolerance in terms of what the body will accept as correct. I don't mean they're not tolerant personalities with other people, but I meant they have a low tolerance within the body. Those type of people will lock up and clench up at night, and it can be for as much as 5 hours at night. Parafunction, we call this. This, you can put 20 stone per square inch of force, which is about 130 kilograms per square inch. I'm mixing units there, I'm afraid, because I think in old money of stones and inches. I'm sorry, it's not very European or probably North African, but there we go. It's a tremendous force, and that force, if you're a clencher for 5 hours at night and locked in, you're causing stress fractures in the teeth. You're making the teeth are becoming sensitive. We're getting abfraction at the necks of the teeth, and we're pinging prisms of enamel off. We're then getting some gum recession because the outer, the very thin outer chamfer of bone on the alveolar bone is also fracturing off, and then the gum is following this renewed bone level. So we have very sensitive teeth. We have a lot of spasm in the jaw muscles themselves. Sensitivity. There's a whole gamut of things apart from broken restorations, broken cusps, etc. So a lot of the restorations that the dentists are now doing on their patients is related to a form of bruxism, and you can pick this up often if they've got a lot of cracks, a lot of broken cusps, or they've got wear facets on the tooth. I was going to show you that on the presentation. But those people, if you use toxin in the muscle to make it smaller, they will continue with their habit and they will build the muscle back up. That's why I use a dental splint. And I've been wearing one myself for 35 years, which is why my masseter muscles are very, very slim. And if you use the appliance as well as doing the toxin, often you may need to do, I do the toxin slowly, so I may do 2 rounds of it at 6 or 8 weeks apart. But then
if they're using Botox and splint together, they give a better results than injecting only Botox into the muscle.
Oh, absolutely, because the face is not.
May I take you back to something? May I take you back to the lips and cheeks?
Yes.
We cannot end this webinar without knowing your own special, tremendous buttering technique.
The Brady buttering technique. What was your question?
Yeah.
Sorry, Noury, what was your question?
Could you tell us more about the buttering technique?
Yes.
You inject a filler in cheeks using the buttering technique. You do it on the white roll skin border of the upper lip. Could you tell us more about the buttering technique and which type of fillers do you use?
I actually use the buttering technique all over the face, except for the nose and the lips and the tear trough. So because tear trough, you're working deep. On the nose, you're working at a deep level, so it's not applicable. I'm using it really, I can use it across the forehead. I use it across the cheeks. I use it across the chin and the perioral area. And my idea here of the older perioral area is such, my analogy is a drawstring bag. It's a bag that has a drawstring at the top, and you pull on the strings and you draw the bag together. I have a diagram, as you know, on my presentation. And women very commonly come in and they don't like the perioral lines. But they say to me, I'd like you to treat this, but I don't want you to touch my lips, because they've got this thing in their head. They've seen on television, they've seen the celebrity pictures of these very, very large lips. And they say, I don't want anything like that. My husband would kill me. And they think that that's what lip.
On the other hand, we have a lot of girls who are obsessed with those shape of the lips.
Some people like it, but the type.
On the other hand, we have some girls who are obsessed with celebrities who have those extremely large lips.
I'm sorry, I lost you a little bit there, Noury.
I'm telling you that on the other hand,
yes,
we have a lot of girls who are obsessed with the extremely large lips because of the celebrities.
Yes, I think that this started probably because I think some celebrities started to have their lips done before it was really practiced I think celebrities started to have their lips enhanced quite a long time ago, before we got these clever lip designs. And therefore, because they're celebrities, this is my theory, the young people follow celebrities. So they assume that that is a good look until it becomes a good look, because everybody then wants it. I think you have two camps of people. You have those people who want to walk around with something that's been obviously done. They want to look like they've had treatment. And I think you will find the same of other enhancements of the body. For example, the breast enlargements. You will find people that want to be extremely well endowed, whereas others want to be more subtle. And we have two camps. We have the patients who don't want anybody to know that anything has been done. They just want to look beautiful. And then we have the other group who want to show off what
Actually,
they've done.
those are the majority of the patients. Yeah, and those are the majority of the patients who are looking for a natural look.
Mine, absolutely. I don't really get patients coming to me for unusual looks. They've seen my work on Facebook and Instagram before, and they come to me because they like what I'm doing, because they say you can't see, they look beautiful, but you can't tell that they are manufactured. I like to do faces in a way that makes them look as if that is how they matured at 20. That it's absolutely 100% the patient genetically. And I don't like to cross the ethnic barriers either. That is more common now, and I'm not saying it's wrong, because I understand that some of the people from the East rather prefer some of the Western features. And in the West, we maybe like sometimes to have the eyes more slanted upwards. So I think some of the most beautiful faces now are a mixture of Western and Eastern features together. And you see this in the multiracial society now, where you have got people with parents from both the West and the East. They can produce the most beautiful children and adults. And therefore, I think sometimes it's as if they meet in the middle. But I do think that my patients tend to they come to me because they know I will do very, very natural treatments. And those are the awards that I have won for.
Doctor, speaking of which, how can you decide if you are gonna do a lip augmentation, putting into consideration that the upper lip is 1/3 and the lower lip is 2/3, and when can you say, or when you will do a 50-50 upper and lower lip by making them an equal size each other?
Okay, if you look at mine, I am 1/3 to 2/3. I think that on some people you cannot make them 1/3 to 2/3.
Yes, I have my lips at 50-50, I guess.
Yes. Now, I would say that men are generally more 1-to-1 and women are generally 1-to-1.6. But that is maybe what we call a golden proportion, a general rule. But if a female naturally has a larger upper lip, then to make the lower one 2/3 of that size, particularly if they have a small chin, would look ridiculous. So you've got to be able, the thing is, you mustn't look at features in isolation. When you look at a feature and you decide the way the patient would like it to be, or the way you would ideally like it to be, you have to look at the rest of the face immediately and decide whether that will fit the bill, whether it will fit the picture. And then you've got to change what you think is the ideal and you've actually got to put that into proportion with the face that you're dealing with. So if they've got a much wider face, for example, maybe they have masseter hypertrophy. But the lips can actually become what they can be made to look wider, even beyond the mid-pupillary line. They can make them look wider and it will still look okay. If that patient's got a very narrow face, if you make those lips look a little bit too wide, they will look like a frog's mouth. So everything has to be balanced. It's like you throw a pebble into the water and it makes concentric circles. And the face is almost concentric circles, that you've got to look beyond the circle that you're dealing with to check that everything is in proportion.
And from here comes the title of our webinar today, Let's Face It, Expanding the Frontiers of Dentistry.
Exactly, yes. That, because what I'm trying to say by that, I've done a couple of lectures now with that title. I'm trying to say to dentists, I'm trying to say to non-dentists, non-surgical facial aesthetics, it's the same skill set that we've done dentistry with. It's the same fingers. It's the same injection technique. It's a syringe. It's facial analysis. All the things that the dentist is looking at all day, every day, as opposed to maybe a doctor who is doing facial aesthetics, but is actually specializing on a totally different part of the body. I don't really think that they can have as much background skill in analyzing the face and the teeth and the jaws as we can without actually doing some dental training. My daughter has started doing this subject and she has a very good knowledge of the teeth and the jaws because my husband and I are both dentists. So it's natural for her to know exactly what I'm talking about. But I do think that whereas we need to do, all doctors and dentists alike, we all need to do more anatomical study. And I assist on a wonderful anatomy training faculty, which is down in London at often
So,
at
before you were doing the cadaver dissection.
Yes. I've done a lot of cadaver dissection, and every time I assist or I help instruct, I'm learning all the time. You never see two cadavers the same. They're always different ages.
There are always anatomical variations, even if in a smaller percentage.
Absolutely. So I love doing it. I find that it's called OFA, OFAA, Oculofacial Aesthetics Academy, run by an oculoplastic surgeon called Sabrina Shah Desai. And there are 5 of us in the faculty. And she's a wonderful instructor. And we take about 18 students from across the globe, across the world. And there are various courses that she does, different, all relating to either a different part of the face, mid-face, lower face, or whatever. But getting those anatomical skills and that knowledge, that deep 3D, three-dimensional knowledge, is so important. And that's what dentists need to brush up on, because at dental school, you don't do it in enough detail. And it's exactly the same with the doctors, because they don't do it in enough detail either. We do a general detail, but they don't do enough for with reference to the anatomical layers that we are working in when we are sandwich techniquing. So we have to know where the most dangerous areas of the face are, where the vessels are more likely to run, because they cross from deep, where they come out of foramen. They cross the tissues, they'll travel deep, then they'll suddenly come up through the muscles, for example, the facial artery, and then it will come up through near the modiolus, and then it will come more superficial from a very deep position, and it will come into the nasolabial area in the subdermal fat. And the awful thing is, when I first started in 2004, that was my first training course down in London, we were being taught with needles. I don't think cannulas in that form existed at that time. Well, they didn't. And we were being taught to put needles in a fanning direction or a threading direction into the subdermal fat in the nasolabial area. We know now that that is just so dangerous. And in fact, somebody had treated me. It was one of the trainers for QMed, which was Galderma, but in the early days. And she hit my facial artery, but it sort of the angular artery at that point. And within a split second, my face went black. And the pain was a searing pain. Even though I had local anesthetic in place, it was actually on this side. Now, what I didn't realize at the time, because nobody had ever mentioned complications on any of the training courses, was she obviously went through that vessel, but had she ended up in that vessel with some hyaluronic acid dermal filler and blocked it, there was no hyalase back then, no enzyme to reverse it. There was no training, there was no knowledge. I could have ended up going blind, because I could have ended up with necrosis of my nasolabial area, my nose.
So that's why it's very important and crucial for any clinician to be fully aware of the anatomy and to have a proper knowledge of what he is doing to avoid any complicated side effects.
I think you have to regard
because a lot of people who are not doctors are practicing Botox.
I know.
There are some beauty salons and makeup artists who are using those stuff.
It's very, very worrying, because I think almost, when you start to learn to drive in a car, one of the first things they tell you to do is put your safety belt on. And hopefully these days you will be in a car that's got airbags. They're thinking about the safety issues before you even start up the engine. Why in facial aesthetics are people learning to do things and only later on down their career they start to take on board complications, how to deal with complications? I think what you've got to think is that on most places in the face, the worst case complication can be blindness, and you've got to bear that in mind every single time you pick up a needle or a cannula. It's less likely with a cannula, but if you use a cannula in a rough way, like a battering ram, and you think it's a needle and you shove it through fast like a sword, you have as much chance of going into a vessel as you do with a needle. But if you use it so gently that you creep through the tissues like I do, you glide hopefully by the vessels, the nerves and the blood vessels, pushing them to one side, out of the way. And you shouldn't even cause any bleeding whatsoever. What you have to remember is that the internal carotid system and the external carotid system, they actually come back. One goes through the skull and feeds the eye and the brain. The external feeds the outside of the face. And they actually anastomose and join and hold hands again here, just at the medial part of the eye, the supratrochlear, absolutely. You've got the lateral nasal, dorsal nasal vessels, you've got the supratrochlear, and you've got the supraorbital, and they have a direct communication. Also, the branches from the superficial temporal. That's right. And they all connect up. So if you get a blockage, for example, on the lips or in the nasolabial area, on the angular artery or on the lateral dorsal vessels, and you stop the blood supply, you cause like a roadblock so that no vehicles can get through. It's a traffic jam.
It's kind of a full network that is connected to each other. Whenever you're going to block one road, the whole roads are going to be blocked.
Exactly. It's an absolute log. It could be that you have a small blockage, but you've got some main routes still open. So a little B road is blocked, but you can get round on the bigger roads. But if the bigger roads get blocked and they back up so that the smaller roads get blocked, you can get a situation where very, very quickly the tissue is deprived of oxygen and the cells start to die very, very quickly. They go through, it interrupts the Krebs cycle. But just as badly, you can get not just a blockage, you can actually get an embolism, and you can get it traveling up the vessel. And in worst case scenario, it can actually get sucked back into the orbital vessels, cutting off the blood supply to the eye. And in worst case scenarios, even a few cases into a stroke, where you're getting interruption to the brain.
Cavernous sinus thrombosis?
Yes. So I'm sorry?
Cavernous sinus thrombosis?
Oh, yes, absolutely. Okay. Sorry, I lost you, Noury.
May it enter to the meninges, to the brain, causing cavernous sinus thrombosis, or it's gonna just lead to optical, to cause a vascular occlusion for the optical arteries?
Yes, I heard part of that, Noury, but really,
is it just gonna cause a vascular occlusion for the optical arteries, or it may be even extended to cause a cavernous sinus thrombosis and reach the brain?
Yes, quite. Okay. So if we on every single case that walks,
if the patient didn't get blind, he may die. So it's like one of the worst scenarios is gonna happen.
Well, even loss of vision in one eye is pretty catastrophic for a patient. So and you've got a sort of a very small window of time to get this reversed, and a lot of the ophthalmic departments maybe wouldn't be particularly well, you've got to get them to an eye hospital in the first place within a short window of time, let alone get somebody that knows how to deal with this as well, with something like a retrobulbar injection, and whether that would...
not expert in dealing with this stuff and in management of those cases.
Yes. So really, when people, every time a case comes through the door, it's not good enough to think, well, I'll learn about complications further down the line when I've got a little bit more money to do another course or something like this. I really do believe, like the seat belt on the car before you set off, that people should be doing a cadaver dissection course at the very beginning. It shouldn't be treated as a luxury course later on. They should be dealing with... They should be learning
how to... It's a necessity for them to understand anatomy. Yeah.
I'm sorry, Noury, you cut off then.
Yeah. I said it is a necessity for them to understand anatomy.
Absolutely, yes. You got to think that at some stage, if you do enough cases, you will have some form of complication. Now, I have a but there, and that is, I think complication rates probably increase also with speed and number of cases going through in a day. I put, touch wood, I put the fact down, the fact that I have, touch wood, very few complications, and I don't want to tempt fate here, but I think it's definitely connected with the fact that I take my...
Yeah, and of course they will say like, they will stay like this because you are totally an expert. So I guess you are not going to have any
Well,
complications anymore.
I like to think that I treat less patients in the day and I treat them very, very slowly and carefully. I inject slowly, I work slowly. I would prefer to see less patients in the day and get absolute perfection on each face than twice as many cases or three times as many cases and not get that perfect look. And you've seen some of my cases today in the presentation when it was working. And, you know, I am so satisfied with those patients are so
I'm
thrilled.
actually, Dr. Ruth, I'm not complimenting you, but I'm saying the truth. You are very precise in your work, and you do it with passion. So maybe
I
those are the key elements for your own success.
I think whatever I've done in life from when I was younger and I took up needlework, well, even when I was 3 years old, my mother bought me some socks with stripes. They were stripes that went across. And I would walk a few yards and one of my socks would drop down a bit and I would stop and I would lift my sock up till all the stripes matched all the way across both legs. Then I would walk a little further and one of my socks would drop down. My mother never bought me striped socks again because I have an obsession with parallel lines and neatness. And this took me into when I was doing a lot of needlework as a child. When I was only 8, 9, 10, I was designing my own dresses. And I was putting in more and more fine detail. I was making the patterns more complicated to put in extra detail. And I would sit up when I was at university and I was sewing, I would sit up till 3 o'clock in the morning, making sure that a line of stitches, every stitch was precise. And my mother used to, it drove her mad. But once they were all in the right place, then I just had 100% satisfaction. And everybody that works with me and the people that I train in the one-to-one training sessions and I run a study group, they know this, they understand this. And that's what I think you've got to strive for. I don't do this subject for money. I retired from dentistry and I do it for passion and I do it because I love it. And I love assisting other people. I love training other people. And I do a lot of teaching for nothing because I love to see the younger generation, you know, people in their 30s. I want to set a good pattern for them. And it's almost an honor to teach them. Just to see them come on. And I love to take them from a beginning of a session where they can't use a cannula. And by the end of the day, while I'm standing with them and showing and guiding them, they can do the buttering technique beautifully, just as well as I can. And that gives me such satisfaction. And
I saw them, Dr. Ruth, and I saw the amazing feedbacks from the people who took the one-to-one course monitoring with you, actually.
oh, you saw that, did you?
Yeah, I told you, I studied you very well.
I know. If you weren't so passionate about the subject yourself, and somebody told me that they'd seen my Facebook right through with the detail, I would have thought I was being stalked. But because you're so passionate about your subject as well, I mean, you have a master's in max fax surgery and you've done theses on this subject, like the gummy smile. The moment I knew that, I realized that, I realized that you are very much like I am.
Yeah, it's true, Doctor. Actually, we have reached the end of our webinar. It has been a great privilege and honor to have you in my webinar. I truly learned a lot from you, and you are such a lovely lady, and you are very modest. And I'm sure that all our audience have learned as I learned from you. I hope we can catch up with you anytime later when you are available. can do the presentation proper.
Absolutely. I'm so sad because we got the presentation up and running today, didn't we? It was working perfectly.
At least we had that chance to tease them a little bit with your teeny little information. We just warming them up with your information.
And may I encourage people to look up on my Instagram account, which is Dr. _ Ruth Brady _ Aesthetics, and my Facebook. I have more cases actually on Ruth Brady, but also I have the page which is Dr. Ruth Brady.
I will post the Facebook page and I will post the Instagram page as well. Add a comment as the video. They can fully view your profile. Again, it's such a great privilege to have you, Doctor.
Well, it's been an honor to have been asked. It truly has. And we have to thank Dr. Tim Pierce, really, for asking me. It's come from that, hasn't it?
Let's hope I can do a webinar with him too, and we can discuss a lot of other topics as well.
And may I just mention my team at ACOM in near York in England. It's sort of in the middle of England, and
at the ACOM Dental Practice as well.
ACOM Dental Practice. It has the most fantastic team of people. It's part of the Portman group of dental practices, but my nurse was the case Karen that you can see on my favorites. It's the little favorites in the circles on the Instagram. She is one of the best dental nurses and facial aesthetic nurses that the world has ever seen. And it was an absolute privilege to be able to put her face into a way that she wanted. You know, I was able to sort out the gummy smile and reshape her cheeks and her chin. And I've never known a patient more deserving of having such a beautiful face as she does now. She's absolutely stunning.
This is sweet and lovely. Thank you so much, Dr. Ruth, for your time. And I hope we can catch another time with you so we can make the presentation. Thank you so much.
And to everybody watching, have a lovely weekend. And it's been a privilege being on your I was going to say on your show. on the Noury show.
I hope when all this is over, you will be able to come to Cairo and visit Egypt. You will totally love it.
That's very kind of you, and I look forward to being able to show my presentation another day. We'll make sure
set up a date whenever you are available, and we are going to show it. And I'm sure that all the audience will be glad to hear again from you.
Well, during this time of coronavirus and COVID-19, none of us are treating patients at the moment, so we're not out having a party. So I'm available most of the time, so we can link up again. And I think we'll have a practice run first.
We will, Dr. Ruth, we will for sure. Thank you so much for your time. And
thank you very much indeed. Thank you.
السيمينار يا رب تكونوا استفدتوا. تابعوني ان شاء الله هيبقى الفتره اللي جايه في حاجات اكتر. We would like also to thank Devonmark for their marketing and organization of this webinar.
Oh yes, thank you.
Thank you so much, Dr. Ruth, and good night.
Good night, Noury. Thank you very much indeed. Thank you. Bye-bye, everybody.
Bye-bye. Bye-bye.
Look me up if you come to England.
Thank you, Doctor. Thank you so much.
Thank you.